Good morning. This week we are going to talk about the renal system. We are going to talk about some diuretics. We have a lot of information to cover. This is week 13 of Pharmacology 110. So we know there's just the basic components of our renal system. So we have our kidneys, one on the left side, one on the right side. We also have two ureters also that come down from the kidneys, one on the left, one on the right. They both lead into our urinary bladder, which stores and holds all of the urine that our kidneys make. And then we know that our urethra is that small area that allows the urine to exit from our body. This is just a more in-depth picture, gives you a little bit more information about the inside of the kidneys. Some of this should be a refresher from you from biology, and then also a little bit more information about the inside of the bladder, the different layers. All right, so we are going to talk about diuretics. So we do give our patients diuretics for a variety of different reasons, mainly if they have a lot of fluid buildup in their body, we want to be able to get rid of it. A lot of our patients who have CHF stay on diuretics for the rest of their life. And then a couple weeks ago when we were talking about blood pressure medicine, we also said that sometimes when our patients first present with blood pressure medicine, this is that first line of medications that we try and use. We try and give them that diuretic. So the reasons that we would use a diuretic, the function of a diuretic actually is we want to be able to increase the amount of urine that's produced by the kidneys and then increase that sodium excretion. So we know that if we excrete sodium from the body, then we know that we will also be able to secrete fluid because fluid will follow that salt. You'll learn more about that next semester in 111. All right, and like I said, the reasons why someone may take a diuretic, well, we would use it to get rid of that edema that we see associated with patients that have that congestive heart failure. We could also use it for patients that have pulmonary edema, patients that have liver disease. So especially those patients who have cirrhosis of the liver, which we've talked about a little bit, they get that really big belly. It looks like they're pregnant. They have that ascites. We can use that to help pull some of that fluid off. Obviously, if patients have renal disease and their kidneys aren't functioning, they can't get rid of that fluid. So we have to give them diuretics. Hypertension, we kind of talked about that a little bit. And then for patients that have or conditions that cause hyperkalemia, which is an increase in potassium, we're going to want to get rid of that sodium and get that fluid to follow. So we do have a couple different classes of diuretics. There's a couple different kinds and they work different ways. So we have thiazide and thiazide-like diuretics. We also have another class called loop diuretics. We have carbonic anhydrase inhibitors. We have potassium-sparing diuretics and osmotic diuretics. And we're going to talk about each of these in detail. So they work a little bit differently inside the body in that kidney, right at that nephron, or they use some type of a different mechanism. So they all work differently to get that fluid off. So these are the sites of action that we see with the diuretics. So thiazide diuretics will work right here where this distal convoluted tubule is. Your spironolactone, you'll recognize that in a couple of minutes. We're going to talk about that, will work in this area as well. Then you have this descending loop of Henle. Those carbonic anhydrase inhibitors will work there. Our osmotic diuretics will work outside here into the kidney. Loop diuretics will work right here in this loop of Henle, which is why they are called loop diuretics. So the first medications that we're going to talk about are our thiazide and thiazide-like diuretics. So we use these to treat hypertension. and to reduce fluid that we see building up in the body. So the most common medications that we use that your book will talk about is the hydrochlorothiazide. That's kind of like the gold standard that I see prescribed for hypertension. Diuresis is another medication, and then diarrheal. So those are the most common, and your book does talk about these. So these thiazide and thiazide-like diuretics will work by, they reduce the kidney's ability to be able to reabsorb salt and water from the urine, and then it won't get into the body. So it's going to decrease the production, it's going to increase the production, of urine output. So it's going to diurese, it's going to get all that fluid out. So the actions for this medication, it does work to block that chloride pump inside the kidneys. It keeps chloride and sodium in that tubule to be excreted in the urine, and then it's going to prevent it from being reabsorbed into the vascular system. We would use this medication for high blood pressure, the treatment of patients that have CHF, those liver patients that have ascites, renal disease, and then we can also see it added on as adjuncts or monotherapy for other treatments of hypertension and sometimes other diuretics as well. Sometimes they might need more than one type of a diuretic. So they're well absorbed from the GI tract. They are metabolized in the liver, excreted in the urine. So we're going to be watching those liver enzymes and those kidney enzymes. We would not want to give this medication to a patient who has any allergies to any sulfonamides or any thiazides. Patients that suffer already from fluid and electrolyte imbalances, and patients that have obviously severe renal and liver disease, we would want to use cautiously with those. So whenever we're pulling fluid off the body, we always have the ability to cause a fluid and electrolyte imbalance. We talked about this a little bit, and it's always kind of like a very fragile balancing act between taking off too much fluid or taking off not enough fluid. But whenever we start pulling these fluids off, we start changing their electrolytes in their body, which can also contribute to an imbalance in their homeostasis, and we don't want to do that. So if they have those, electrolyte and fluid imbalances already, we just want to use those, use these medications cautiously with them. For patients who have bipolar disorder, it could exacerbate the changes in the calcium levels that usually occur with those drugs that we use to treat those. And then, of course, we want to use cautiously in patients who are pregnant and lactating. For patients who have gout, these can counteract with those medications. It can cause an abnormal amount of reabsorption and secretion. For patients who have systemic lupus, it can cause glomerular changes in the kidney and renal dysfunction that could cause renal failure. With diabetes, we know it's going to be worsened because of the glucose. Some of these diuretics will cause the glucose levels to become elevated. So have to use cautiously. And then our patients who have hyperparathyroidism, it could cause that condition to be exacerbated because of the effects that we see on the kidneys. So adverse effects, patients can develop hypokalemia. So that's a low potassium because potassium is going to be lost in that distal tubule that we showed you where that was earlier. And hypokalemia may result because of that. So the signs and symptoms that we would want to look out for is these patients will report that they're very weak. They can report muscle cramps, and then they can develop arrhythmia. So remember, we said that potassium affects the muscles, whether it's high potassium or low potassium, whatever the issue is, whether it's high or low, it's going to affect the heart because our heart is a muscle, and we see that potassium really affects our muscles. So these patients are always going to want to be on cardiac monitors. And then patients who are taking these diuretics and they also take lithium, there is a possibility that they can suffer from lithium toxicity when you combine these medications together. So we would just want to make sure that if we have a patient that's taking lithium and we put them on diuretics, we really want to monitor those lithium levels and make adjustments as noted based upon those findings. These medications also cause a decreased calcium excretion, which can cause the calcium levels in our blood to increase. We talked about the altered blood glucose levels, and then we should expect that our urine is going to be a little bit alkalized. Drug-to-drug interactions for patients who are taking cholestyramine, we're going to see a decreased absorption with these medications if combined together. If it's mandatory that these medications both be taken, it is a recommendation that we take the medications at least 2 hours apart to decrease that likelihood of any drug-to-drug interaction. Digoxin, which is that heart medicine that we talked about last week, we do see that if these medications are combined, it increases the patient's risk of suffering that digoxin toxicity that we talked about, because we're going to see a change in those potassium levels. So we're going to make sure that we're monitoring our potassium and our digoxin levels. And then for patients who are taking those oral insulin, any kind of anti-diabetic agents, we're going to see a decreased effectiveness in those medications. So we might need to change those doses to get the benefit to lower the blood sugar the way we need to get it lowered. So next, we're going to talk about our loop diuretics. Our loop diuretics are diuretics that act in the ascending loop of Henle in the kidney. Furosemide or Lasix is the most commonly used. It's been around for a very long time. It is less powerful than some of the newer drugs that we see that are out on the market, but there's also a larger margin of safety for home use. So remember I said a lot of these patients who have these chronic conditions, heart failure, liver issues, renal issues, they have to take this at home on an everyday basis. So we do see that although it's not as powerful, it's definitely more safer. Bumex and Demotex or furosemide are another couple medications that I see prescribed more often in the clinical settings now. They are those newer type of drugs, definitely more powerful. I do see sometimes that they will combine these medications at different parts during the day to get to get the levels that they need to see in these patients. So loop diuretics work by blocking the chloride pump, in the ascending loop of Henle. When they block that chloride pump, this is going to cause a reabsorption of sodium and chloride. So we would give this for patients who have CHF, pulmonary edema, edema associated with CHF, any kind of edema associated with renal or liver disease, and then hypertension. So these medications are going to be metabolized in the liver and the kidneys. We would not going to give these medications to any patient if they had an allergy to any part of these medications. One big thing that we're going to monitor with these patients every day is their electrolyte depletion. So this is something that frequently happens when we give Lasix. So in the morning, if you get a report or you see in your medication that your patient is on loop diuretics, Lasix, butamide, whatever, you're going to make sure you go in and check those labs in the morning. You're going to look at the sodium, you're going to look at the potassium, you're going to look at the magnesium, the calcium. You want to look at all those electrolytes to make sure that we're not losing. Potassium is the main one that we lose, that we see usually. So because then they're going to have to give them, you're going to have to supplement their electrolytes. If a patient is anuric, we would not want to give them this medication because of they are not able to make urine in their kidneys. So that would be an issue. Severe renal failure, because it can prevent the diuretic from working, and it can also cause them to go into a crisis stage. So we do have to use these medications very cautiously. Hepatic coma, which could be, so this is an issue with the liver, which we could see this issue become exacerbated because of the fluid shifts that we're going to see when we're giving this medication. And then we want to use cautiously with patients who are pregnant and lactating. Also going to see an issue with patients who have gout. It can cause gout or make it worse. Diabetes, we know it can worsen their condition because of the glucose elevating effects. It increases our glucose, these medications. Adverse effects we know are going to be related to those imbalance of those electrolytes and fluids. So hypokalemia, we know that this is an adverse effect because we're losing that potassium when all that is occurring with the diuretic. Alkalosis sometimes happens. We see a rise in our serum pH. We're going to talk more about this next semester in homeostasis. We see this happen because we lose a lot of bicarb in our urine. And then hypocalcemia is also, they're at risk for that because calcium is going to be lost in that tubule along with the bicarbonate. So we might see hypocalcemia. So these are things you would want to watch out for. Drug interactions are aminoglycosides or cisplatin. The risk of ototoxicity is going to increase. So that's our hearing, right? Remember that from a couple of weeks ago, we talked about medicines, the 3 mice with the antibiotics that cause the loss of hearing. So patients taking these medications, we would want to monitor their hearing. We know that it's going to increase our anticoagulation effects if they are given together. And then we do see that if the loop diuretics are taken with indomethacin, ibuprofen, other salicylates or NSAIDs, that there's a decrease for loss of sodium and a decreased antihypertensive effect. So we would want to monitor the blood pressure and that serum sodium levels. All right, so next we're going to talk about our potassium-sparing diuretics. So these are diuretics that still pull the fluid out, but they do not promote the secretion of potassium. So it's going to hold on to the potassium, which is good for some patients. So these medications, this is your aldactone or your spironolactone or your amyloid or your amilimont. So this will cause a loss of sodium in the body while retaining that potassium. It's going to work by blocking the actions of aldosterone in the distal tubule. So we see that sometimes these are prescribed as an adjunct to those thiazide or loop diuretics. And for those patients that really suffer from hypokalemia to begin with, this is probably an ideal medication for them. So they are well absorbed. They do bind to proteins in the body, and they're going to be widely distributed. They are metabolized in our liver and excreted in our urine. Any contraindications to giving these medications? Obviously, if they have an allergy, if they already suffer from hyperkalemia. So hyperkalemia is increased potassium levels. If their potassium levels are already increased, we don't want to hold on to it anymore. Okay, so we're going to see an exacerbation of that increased potassium level. Renal disease can also cause issues if we're holding on to that potassium. It can exacerbate their issues even further. Anuria, if they're already anuric, it can cause that to become even worse. And then we want to use cautiously in patients that take amyloid and triamterene. Adverse effects, we know, we just said, is that hyperkalemia. So this is the most common adverse effect that we see from these potassium-sparing diuretics. So patients that suffer from hyperkalemia, they're going to complain of ataxia, muscle cramps. We're going to see those cardiac arrhythmias. Remember, the heart is a muscle and potassium affects the muscles. Lethargy, we might even see confusion. These patients definitely want to be on cardiac monitoring if they have these high or low potassium levels. We have to make sure that we are regularly evaluating them for this increased potassium. We want to educate them about the signs and symptoms to watch for. And then we also want to tell them that while they're taking these, they should probably avoid foods that are high in potassium. So those foods are going to be your bananas, your grapefruits, oranges, any type of dried fruit, navy beans, prunes, sunflower seeds, lima beans, peaches, watermelon, cantaloupe, potatoes, spinach, and coffee. There's a lot of medications that, a lot of foods that have potassium in it. And then drug interactions, if we combine these potassium-sparing diuretics with salicylates, it's going to decrease the diuretic effect. So we just want to be careful about that. And then we have our osmotic diuretics. So an osmotic diuretic is a type of a diuretic that inhibits the resorption of water and sodium. So mannitol, also called osmotrol, is an IV medication only. So what these medications do is they pull water back into the renal tubule without sodium loss. So we're not going to have any sodium loss there. We would give these to our patients who have increased pressure in their cranium, or if they have acute renal failure, maybe because of a drug overdose, or they've had some type of trauma, or their body's in shock. So these are going to be freely filtered at the glomerulus in the kidney, and they're going to be poorly reabsorbed by the renal tubule. They're not going to be secreted by that tubule of the kidney, and they are pretty resistant to metabolism. This medication is usually given in the ICU setting. This is not a medication that I've ever given on the med-surg floor. We would not want to give it to patients who are anuric, who have severe renal disease, because we know when we see that, whenever we give a diuretic, we can see the potential for large shifts of fluid. So when we give these diuretics, seeing that large shift in fluid can cause an exacerbation of their renal disease. Patients who have pulmonary congestion, we see that it can also exacerbate those issues. For patients who are suffering from dehydration or intracranial bleeding, they're also subjective to those large shifts of fluids, which can exacerbate those issues. And then CHF the same way. Those large shifts in fluid are going to cause an exacerbation of their issues. So we would want to use those other medications. Any adverse effect. So we want to think about anything that we ever give that's going to cause a change in fluid levels in the body, that's going to affect their circulating blood volume. Their circulating blood volume is their blood pressure. So we're going to expect that we can also lower their blood pressure because we're giving them a medication that's going to lower their circulating blood volume. So this is something that you guys want to keep in mind when you have that patient who is getting a hypertensive medication in the morning, and maybe they're also in some type of pain and they're getting a pain medication. So if you think of it in the perspective that all three of those medications have the ability to decrease our circulatory volume, it could be very dangerous. So this is why we want to monitor their blood pressure before we give these medications. And we also want to monitor them very closely after we give them. Even if the doctor says, yes, I want you to give these medications, you would just want to monitor their blood pressure within an hour. So those adverse side effects that we're going to see are going to be related to that drop in those fluid levels. We might see headaches, confusion, lightheadedness, hypotension, nausea, vomiting. All right, so just to test your knowledge a little bit, the nurse is instructing a patient receiving a loop diuretic to report yellow vision, B, weight loss of 1 pound a day, C, muscle cramping, or D, increased urination. So in this instance, the answer would be C, muscle cramping, because we said that when we give those loop diuretics that it can cause low potassium levels. And we know that potassium will affect our muscles. So we want them to be aware of muscle cramping and we want them to be able to report that to us. When providing care to a patient who is receiving a loop diuretic, the nurse would determine the need to regularly monitor which levels: sodium levels, bone marrow function, calcium levels, or potassium levels. So for this question, the answer is going to be D, because we've been talking how it does decrease the potassium levels. We were talking about muscle cramping. So we need to look at all the electrolytes, but especially the potassium. The nurse would anticipate an order for a loop diuretic as the drug of choice for which patient? A patient with hypertension, a patient with septic shock, C, pulmonary edema, or D, fluid retention of pregnancy. And in this case, the answer is C. We talked about that. This is an adequate medication, ideally for pulmonary edema. And the last question, thiazide diuretics are considered mild diuretics because A, they block the sodium pump in the loop of Henle, B, they cause loss of sodium and chloride with but little water, C, they don't cause fluid rebound when they work in the kidneys, and D, they have little or no effect on electrolyte values. So the answer to this question is B, they cause a loss of sodium and chloride but little water. All right, so now we are going to talk about drugs that affect our urinary tract and our bladder. So we know that our patient population, especially our older adults, are very, very susceptible to developing urinary tract infections. You certainly will encounter this in your clinical rotations and as in your practice. Urinary tract infections, UTIs, are the second most common infection that we do see in the United States. We know for good reason that they are the most common infection in females, because females compared to males have that much shorter urethra. So it doesn't take any time at all for that bacteria to get up there and into the kidneys. And then patients with indwelling catheters or intermittent catheterizations are at a risk. So every time we have to do an intermittent cath or we have to go into that area, we always run the risk of infections. Why it's so important that we always practice sterile technique and we advocate for our patients. So if you have a patient that's chronically in the hospital and they're chronically retaining that fluid and you're having to bladder scan them and they're not putting out any urine, it's probably after the first one, maybe you want to make a note, make a phone call to the doctor and say, hey, this is an ongoing issue with him. I'm worried about him getting a UTI. I think it would be safer to just put in an indwelling catheter for right now. And then also being able to recognize when that catheter should come out. So we do have something, it's a nurse-driven protocol in the hospital that when the doctor puts in an order for a Foley, nurses have the right to reevaluate whether or not that Foley is still advised and that we can take it out to decrease the risk of infection. So that certainly would be something that you would want to do, because we know that the longer those catheters stay in, the higher rate of increase for infection there is. And this is something that Medicare does not pay for. Remember, we talked about things that Medicare does and does not pay for. Those never events, and a UTI inside the clinical setting is one of them. So, signs and symptoms of a UTI. Normally we see urinary frequency or urgency. So they have to go all the time. They can't hold it. They feel like they're not going to be able to hold it. So they have to go very, very quickly. Burning when they urinate. Sometimes we see blood. If it's really progressed, they'll pee blood. Chills, fever, flank pain, tenderness. All signs of a urinary tract infection. When we talk about our older population, especially female patients and males equally, we see that they present a little bit differently. So they may not have the burning and the pain or the urgency that most people have. They will present with confusion. So when you see an older patient in the clinical setting and they are admitted to the ER for a sudden change in mental status, that's one of the first things we want to check is a urine sample, because that is how urinary tract infections present in our older population. So how do we treat UTIs? Usually we treat with antibiotics or specific agents that will sterilize the urinary tract. We also use drugs that will block the spasms, because UTIs can be extremely painful. There's a lot of spasms that occur with UTIs in those urinary tract muscles, so we can give antispasmodics. Usually the medication that we give is butynin. We can use pyridium. Pyridium will help decrease the urinary tract pain. It's also going to protect the cells of the bladder from irritation. And then we use another medication called Tamsulosin, which will treat the enlargement of the prostate glands in men. And usually what happens is when their prostate swells, it's hard for them to start a urine stream or to have good urine output. So this medication will help increase their urine stream. So I pulled this from your book. This is the site of actions where we see all these medications work. That's a good slide for you guys to know. It's very helpful when we talk about these medications. So anti-infectives that are prescribed, we know that they will act specifically within the patient's urinary tract to either destroy the bacteria, either through an antibiotic, either through an antibiotic effect, how we know how antibiotics work, or through an acidification of the urine. They're going to work one or two ways. They do not normally have an antibiotic effect systemically. They're really only activated and effective in the urinary tract. It is very common, especially our older population, for people to become septic from a UTI, and UTIs, when they cause sepsis, can also be fatal, so especially in our older population. So some of the medications that we use, we give Sinovac. Sinovac will interfere with that DNA replication process in gram-negative bacteria. We also have norofloxacin, which is effective against more gram-negative strains than the Sinovac is. We have Monoro, which is a good medication, and it's convenient for people who have a problem taking medications and remembering to take medications because it's only one dose. We have Negram, which is an older drug. I've actually never seen this drug prescribed. It's older and it's not effective against as many gram-negative bacteria as the other medication. And then we have Nitropharantoid. This is prescribed a lot. This is also an older drug with a very short half-life. So the thing about this medication that you would want to educate our patients about is just taking it with meals if they have any GI upset. So then we have anti-infectives that will acidify the urine. Hyprex is one of the medications, and Urolene Blue, methylene blue is the other one. So the Hyprex will undergo metabolism in the liver. It's going to be excreted in our urine. And it has established dosage guidelines so that you can use also in children and adults, and it comes in a suspension form for children. The methylene blue is going to be widely distributed and metabolized in our tissues, and it's going to be excreted in our urine, our bile, and our feces. So for those spasms that patients do suffer with urinary tract infections, we want to give them antispasmodics. So those medications are going to be your Detrol or your Detrol LA, which is long-acting, your oxybutynin or the Ditropan, and your Vesicare. So these medications will block the spasms of the urinary tract muscles. They will block that parasympathetic activity, and they're going to relax that detrusor muscle and other muscles in our urinary tract. So these medicines are a godsend. I don't know if you've ever had a UTI, but the spasming can be very, very uncomfortable, especially when you're peeing. So these medications work very well. So obviously we're going to give them for bladder spasms and dysuria. They are going to be rapidly absorbed and widely distributed, and they're metabolized in the liver and excreted in the urine. Contraindications to taking these medications: anyone that has an allergy. For anyone that has a pyloric or a duodenal obstruction, you would not want to give this medication to them, because this medication has anticholinergic effects, and it can cause a lot of complications for those patients. Any patient that's had an acute hemorrhage, any kind of obstructive urinary tract issues, because it can block that muscle activity and relax the bladder. And then patients who have glaucoma, myasthenia gravis, or like I said, maybe some type of recent surgery, and they have that hemorrhage, those issues can all be exacerbated and they can be worse because of those anticholinergic effects. We want to use cautiously, obviously, in people who have renal or hepatic issues, and then our pregnancy and lactating. Adverse effects to the medication are going to be related to blocking that parasympathetic nervous system. So if we do that, we might see nausea, vomiting, dry mouth. Patients might report being nervous. We might see an increase in their heart rate. They might report vision changes. If we have a patient that has a UTI and they're taking phenothiazines or haldol, we're going to see a decreased effectiveness in those medications when combined with these antispasmodics. So urinary tract analgesics that we can give pyridium. Pyridium, when it is excreted in the urine, it exerts, it allows like a topical analgesic effect inside that mucosa, inside the urinary tract. It does relieve symptoms related to that irritation that we see from a UTI, maybe a recent surgery or any kind of trauma. It's rapidly absorbed and has a very rapid onset of action. It is widely distributed, metabolized in the liver and excreted in the urine. This medication will cause their urine to turn bright orange. So that is something that you want to educate your patients about, because they'll get very upset when they go to pee and see that their urine is orange. Obviously, you would want to use cautiously in any type of renal dysfunction, or avoid if you have an allergy. Pregnancy and lactating, always have to be careful. Adverse effects. GI upset, some people will report that they're very nauseated, a headache, some can develop a rash, but definitely that reddish orange color of the urine. You want to make sure you educate those patients about that. And then renal and hepatic toxicity. So we would be monitoring our AST and ALT and our BUN and creatinine. The drug interactions, when we combine these analgesics with antibacterial agents, we risk the toxic effects of the drug. If we happen to use this medicine along with the antibiotics, we should not use them for longer than 2 days. All right, so medications that treat benign prostatic hyperplasia, BPH. That's going to be our Flomax, our Tamsulosin. It's going to be our Terazosin or our Hytrim, or the Hytrim, the Terazosin is also a medication that we have seen most recently that is now being prescribed for hypertension. So it has 2 uses. So depending on which drug you're giving, the actions are going to be different. We do use this for the BPH. Pharmacokinetics, again, it's going to vary depending on which drug you have. You would not want to give if these patients have any type of an allergy. We want to be very careful using in patients that have hepatic or renal function. And our adverse effects, again, very different depending on which drug we're using. Some of the common effects we see: headache, fatigue, dizziness, postural dizziness. These are going to be tachycardia, hypotension, lethargy. So you can see that this is probably why they're good for decreasing our blood pressure, because these are all the symptoms of low blood pressure. And then GI upset. Also, some patients report a decreased libido, impotence, and sexual dysfunction. If you use these medications together with theophylline, which is what we use for patients who have COPD, combining them together can cause low blood pressure. All right, so now we are going to talk about the GI system. All right, so I did grab this from your book. So the GI system is the only system in our entire body that actually opens to the external environment from both ends. So it is actually composed of one continuous tube. It's going to start at our mouth, It's going to progress through our esophagus. It's going to go into our stomach, go down further into our small and our large intestines, and then it's going to end at the anus. We do have what we call accessory organs that are associated with our GI system. Those accessory organs are your pancreas, your liver, and your gallbladder. So our GI system is responsible for secretion, absorption, digestion, and motility. So secretion is, we're going to see it's going to start, actually digestion is the process, is what we see, the process of breaking down food into absorbable nutrients that our body can use. So this process is going to start in our mouth. We actually have enzymes in our saliva. So we're going to take our food in, we're going to chew it up, we're going to swallow. This process is going to continue through our stomach, and it's going to continue through that digestion process. Once our food gets into the small intestines, it's going to start mixing with bile, and it's going to break down the fat molecules. Absorption is what we consider an active process, an active GI process in our GI system that is going to remove water and nutrients and a lot of other different elements from that GI tract. Once we remove them from the GI tract, then we can take them and deliver them to the bloodstream, and our body can grab the nutrients from them and use them. Our motility, if motility doesn't happen, we're not able to complete this process. So our motility is going to be allowing this process to start by swallowing our food, moving it down our throat, into our stomach, into our intestines. We got to keep things moving. So when we talk about swallowing our food, that in the esophagus, that is going to happen by peristalsis. The stomach is also going to continue that type of a churning action with the 3 muscle layers inside the stomach to help keep things moving. The small intestines will use a process of what they call segmentation, and then our large intestines are going to use mass movement to remove everything from the body. So the GI system is controlled by what we call the nerve plexus. So the nerve plexus is going to be responsible for maintaining what they call an electrical rhythm in the body and responding to local stimuli in that GI system. So increasing our GI activity when we need to, and then also decreasing our GI activity when we need to. The autonomic nervous system also influences our GI activity. Our sympathetic nervous system is going to slow things down, and the parasympathetic nervous system is going to be responsible for increasing the activity. So the type of secretions that we see from our GI tract. So we see our saliva has a lot of water and a lot of digestive enzymes in it. Saliva comes directly from our salivary glands, and this is the beginning of the digestive process. Once we take that food in, it helps us to facilitate that swallowing and makes that food, which we will now refer to it as a bolus, more slippery so that it can continue to progress through our GI tract. Mucus is also very important. It's going to be produced in our mouth. And it also protects the epithelial linings. It also helps us to swallow. The esophagus also produces mucus. I can't talk today. The esophagus also produces mucus to protect the lining of our GI tract and to help move that bolus further down. The stomach also produces a lot of different acids and digestive enzymes. So once that bolus gets to our stomach is going to secrete gastrin. That's going to be secreted by our G cells in our stomach. And this is one of our the enzymes that are going to help secrete that acid. And it's going to release pepsin, which will then activate another enzyme, which is going to break down all of that bolus into proteins. Secretin is also an enzyme that is released when once that bolus gets into the small intestine, it's going to stimulate our pancreas to start secreting large amounts of sodium bicarb, and that's going to help neutralize the acid that's in that bolus. We do have a lot of different pancreatic enzymes. Our chymotrypsin and our trypsin will work together to break down those proteins into smaller amino acids. We also have lipases, which will break down the fat, and amylases, which will break down the sugars. So all these enzymes will work together to deliver the GI tract. All these enzymes will be delivered to the GI tract through either our common bile duct and the gallbladder together. If we do have fat in the bolus, the gallbladder is going to recognize that. It's going to start to contract and it's going to release that bile into the small intestine. Our bile will then break apart those fat molecules so that they can be processed in the body and absorbed. Obviously, we see patients who are not able to do this and they have gallbladder issues. So patients that have a lot of fat in their meals and they have bad gallbladders, whenever they eat a fatty meal, they're going to have a lot of gallbladder pain because they're not able to get rid of that fat. And then we have our endocrine hormones, which will be, sometimes we will see in the presence of food, those large intestines along with the small intestines will secrete growth hormones, aldosterone, and glucagon to help facilitate that bolus through the rest of the GI tract. Okay, so the swallowing reflex. So our swallowing reflex is going to be stimulated anytime we take in a food bolus inside of our mouth. It's going to put pressure on those receptors that are in the back of our throat and our pharynx. Once those pressure receptors are started, it's going to send an impulse to our brain where it's going to start stimulating a series of different nerves. Being able to swallow, it involves more than 25 pairs of muscles, if you can believe that. Each muscle works in a different way to help get that food down. Our vomiting reflex is also a very important reflex because it helps protect our system from keeping things in our body that are unwanted. The vomiting reflex is going to be stimulated by two centers in our brain. The first center is considered the more primitive center. That's called the emetic zone. When that zone is stimulated, it's going to initiate that process of vomiting up our food, that projectile and vomiting. That obviously projectile vomiting is more of an intense reaction. We see that usually in children when they're younger or whenever we have a high increased pressure in the brain or brain damage. All right. So we know that it, just like every other part of our body, our goal is to always have homeostasis in our GI tract. Any type of overstimulation in our body can cause an issue. So it can cause underactivity, will cause constipation. And then if our system is too overactive, then it can cause diarrhea. So we're going to talk about different medications that we use that will affect our gastrointestinal secretions. So there's a lot of different reasons that patients will come to the hospital or come to their primary care physician reporting some type of a GI disorder. They're very, very common. And there's a lot of different medications available that patients can use to self-treat their issues, such as just having heartburn, sour stomach, upset stomach, things like that. There's a whole list in your book of the over-the-counter drugs that you can take a look at that patients take. It's box 57.1. But the underlying cause of these disorders that patients see can be a variety of different things. It could be dietary excess. It could be eating too much. It could be eating too less. What are we eating? Stress has a huge effect on our GI system. Some people, when they get stressed, they overeat. Some people, when they get stressed, they have diarrhea. They don't eat. hiatal hernias, esophageal reflux, GERD, and then even medications that we prescribe to patients can have an adverse effect on our GI system and cause them issues. And then peptic ulcer disease can also cause GI disorders. So drugs that we use typically to affect GI secretions for patients that have peptic ulcer disease or disorders that involve any type of GI acid, these medications are going to work to decrease the amount of acid that's secreted. So it's going to decrease the secretory activity of our GI system. They can also block the action of our GI secretions, or they can protect the lining of our GI tract to put a protective covering on there to keep it from eroding and things like that. We can also use medications to replace enzymes that our GI system should have that they don't, or some of them will work on the GI tract when those organs that normally produce the activity that we like to see when they don't work anymore, different medications. So some of the medications that we will see, we have histamine 2 or H2 antagonists. That's going to be your famotidine, your Pepcid, your ranitidine, or your Zantac. They work by releasing hydrochloric acid in response to gastrin. So they're going to keep those secretions at a minimum. They will interact. We have our antacids, sorry. Your antacids are going to be your calcium salts. So that's going to be your Tums or your magnesium salts. So your milk of magnesia, you guys have probably heard of that. These medications work to interact with acids at the chemical level to help neutralize them. And then you have your protein pump inhibitors, which is your omeprazole or your Nexium, the purple pill. These will suppress the secretion of hydrochloric acid into the lumen of our stomachs. So our histamine 2 or H2 antagonists, they will selectively block those histamine 2 receptor sites. Once we block those receptor sites, then we're going to see a reduction in the gastric and acid secretions, and it's going to affect the amount of pepsin production overall. Indications: short-term treatment of an active duodenal ulcer or a benign gastric ulcer. We can use it prophylactically for stress-induced ulcers and acute upper GI bleeding. We can use it for GERD. We can use it to relieve symptoms of heartburn, acid indigestion, or a sour stomach. They're going to be metabolized in the liver and excreted in the urine. We would want to use these medications cautiously in patients who are pregnant and lactating. Watch the hepatic and renal function, because if they have issues there, it can interfere with drug metabolism and excretion. GI effects: these medications can cause dizziness and constipation. We can also see diarrhea or constipation. We can also see CNS effects, so the central nervous system, those dizziness, headache, somnolence, confusion, hallucinations, cardiac arrhythmias, and hypotension. We can see these when these medications are administered IM, so intramuscularly, IV, or with patients who stay on them for a long time. There are drug-to-drug interactions. So if patients are on warfarin, beta blockers, if they're taking alcohol on a regular basis, lidocaine, theophylline, chloroquine, benzodiazepines, nifedipine, penophylline, tricylics, procanamide, or carbamazepine. These medications together with the H2 agonist will reduce the metabolism of those drugs, and it can cause these medications to build up in the system, and it can also cause these medications to have toxic levels in the patient's body. So we want to be very careful. So this is just a little fun slide I found on the internet for the H2 blockers. I have one for each of the medications, I believe. So the protein pump inhibitors, they act at a specific secretory receptor to help prevent that final step in acid production. Then they overall will decrease the level of acids in our stomach. We can use it for short-term treatment of a duodenal ulcer, GERD, erosive esophagitis, and benign active gastric disease. We can also use it for long-term treatment of patients who have issues where they just have a hypersecretory problem. So they just keep on secreting and making acid, and the production levels just don't stop. They're reabsorbed. They are absorbed rapidly in the GI tract. They're metabolized in the liver, excreted in the urine. You would want to use cautiously in any person that has an allergy. Adverse effects, CNS effects, so dizziness, headache, vertigo, insomnia, apathy. Adverse effects could be diarrhea, abdominal pain, issues with their tongue, kind of like tongue atrophy, feels like their tongue is not moving properly. These medications will also can cause upper respiratory tract symptoms. So epistaxis, hoarseness, stuffy nose, cough, they might sound like they have a cold. Other side effects, rash, alopecia, pruritus, dry skin, back pain, and fever. One of the most common things that I see with these patients is diarrhea and abdominal pain when I give it. Your antacids, they work to neutralize the acid directly in the stomach by a chemical reaction. They do give symptomatic relief of an upset stomach associated with increased levels of acid, as well as that hyperactivity. We would want to not give if any patient had an allergy to any part of the medication. We would want to use cautiously with patients that have any condition that could be exacerbated by an electrolyte imbalance. Also with a patient that has any type of GI obstruction, because it can cause systemic absorption of the drugs, and it's gonna, if we systemically absorb these drugs, then we will see an increase in the amount of adverse side effects that we have. So the adverse effects of the antacids is going to be related to whatever medication it is that they have, to the particular medication. It's also going to be related to the effects on the acid, base, and electrolyte levels. They can develop something called rebound acidity. This is where we take the medication, but the stomach continues to make more acid because now there's an alkaline environment. Alkalosis is something that they can experience because it causes metabolic changes. So these patients may present with nausea, vomiting. We're going to see neuromuscular changes, headache, irritability, muscle twitching. And even if it gets severe enough, they could go into a coma. Hypercalcemia is something that we can do. So Tums is calcium. So we can increase their calcium levels. Constipation or diarrhea, hypophosphatemia, so low phosphorus levels. And then we would want to use cautiously with medications that affect the absorption of other drugs. All right. Drugs used to treat ulcers. So we have gastrointestinal protectants. So that would be sucralfate or carafate. These work by coating that area in the stomach that is injured, where there's an ulcer, and they help to prevent any further injury from that acid on that site. It forms an ulcer adherent complex, usually with those duodenal ulcers. It protects against the acid, the pepsin, and the bile salts. It promotes the healing of those ulcers. It's rapidly absorbed, metabolized in the liver, and excreted in the feces. You would want to use cautiously in patients that have renal failure, and avoid if they have an allergy to any type of that part of that medication. We also have prostaglandins that can be used to treat ulcers. Mistoprazole is a medicine that we use. It inhibits the secretion of gastrin and increases the secretion of the mucus lining of the stomach. So it's going to provide a nice buffer. It inhibits gastric acid secretion and increases bicarbonate and mucus production in the stomach. So it's going to help protect it. We can use it for the prevention of ulcers that are developed by people who take a lot of NSAIDs, and treatment for duodenal ulcers. So it's rapidly absorbed from the GI tract, metabolized in the liver, and excreted in the urine. We want to use carefully in patients who are pregnant and lactating. So they are, let's see, we will see that they are rapidly absorbed in the GI tract, metabolized in the liver, excreted in the urine. It can cause GI side effects, so nausea, vomiting, diarrhea, abdominal pain, dyspepsia, constipation in some people. Also, it can cause, has an effect on our GU, so miscarriages, excessive bleeding, spotting, cramping, hypermenorrhea, dysmenorrhea, and other menstrual disorders. So that is something you would want to educate your female patients about. So this is the site of action where we see that these drugs work that help affect those gastrointestinal secretions. So this is a nice little chart. You guys should look at that. I grabbed it right from your book. So there are some patients who require supplemental digestive enzymes. So they don't have the enzymes that they need that should be produced in the GI tract to help break down that food so that we can get it into nutrients that the body can use. So some people, maybe if they've had a stroke, if they've have maybe salivary gland disorders, or they've had some type of surgery in the pretty invasive surgery in the head and the neck, or cystic fibrosis patients suffer with this, or patients that have pancreatic dysfunction. These are the patients that are going to need to supplement that production of those digestive enzymes. So there are 2 digestive enzymes that are currently available for replacement for these conditions. It's going to be a saliva substitute. It's called mouth coat or Salivart. And then we also have pancrelipase, which is also called Creon or pancrease. Creon is the one that I see most commonly used in the medical setting. So the action of these medicines, so the saliva substitute works by, it has electrolytes and carboxymethylcellulose, which acts as a thickening agent in dry mouth conditions. The pancreatic enzymes are going to replace those enzymes that help digest the food and help absorb those fats and proteins and carbohydrates that our body needs for nutrients. So we would give them, obviously, for replacement therapy. Any indication, contraindication would be for the saliva medication if they have an allergy to any part of that medication. For the pancreatic enzyme, same thing. Do they have an allergy to any part of the medication? For patients taking the saliva replacement, you would want to use cautiously in patients who have hypertension, any type of renal failure or congestive heart failure, because it can cause an abnormal absorption of the electrolytes in their body, especially the sodium. We know that the sodium, wherever sodium goes, fluid will follow. So it can cause increased cardiovascular load, so increased fluid. Pancreatic enzymes, you want to be careful with patients who are pregnant and lactating. Adverse side effects with the saliva replacement, obviously complications are going to be from the abnormal electrolytes, so increased levels of magnesium, sodium, or potassium. And then the pancreatic enzymes can cause GI irritation, nausea, abdominal cramps, and diarrhea. All right, a couple questions. A nurse caring for a patient receiving pancreatic enzymes as a replacement therapy should be assessing the patient for A, hypertension, B, cardiac arrhythmias, C, excessive weight gain, D, GI irritation. What do you guys think? The answer is B, cardiac arrhythmias related to those potassium levels. All right. Cytotec is a prostaglandin that is used to A, prevent uterine contractions, B, prevent NSAID-related gastric ulcers in patients at high risk, C, decrease the hyperacidity with meals at bedtime, or D, relieve the burning associated with hiatal hernias at night. And this answer is B. We use this medication to prevent NSAID-related gastric ulcers at patients who take a lot of NSAIDs. All right, so drugs that affect GI motility. So this is another slide from your book. This is all the sites where we see these medications will help affect gastric motility. So constipation, diarrhea, those are the things that we're talking about. So when we talk about laxatives, so we have chemical stimulants, bulk stimulants, and lubricants. So chemical students will stimulate that nerve plexus that we talked about that's located inside the intestinal wall, and it's going to cause increased movement and the stimulation of those local reflexes. So these laxatives that are called chemical stimulants, that is your Bisocodyl, which is your Dulcolax, or your Senna, also called Senecot, or castor oil, or just Senna. Then we have bulk stimulants. So these are also referred to as mechanical stimulants. They are laxatives that are going to cause the fecal matter to increase in bulk. So if we can increase the bulk of our fecal matter, it's going to stimulate those as it increases those. As the intestines stretch, there's receptors in there that are going to be activated. And once those stretch receptors are activated, it's going to propel that stool forward, and it's going to help us to get the bowel movement out. So these medicines work by increasing the size of fecal matter by pulling more fluid in to the intestinal contents. So these medications are Citracel, Fibrocon, or Metamucil. Then we have lubricants. So sometimes we want to just make defecation easier without stimulating the movement of the GI tract. We just want them to be able to get the bowel movement out easier. So we can do so with these lubricants. So patients that have hemorrhoids will use these. Patients that may have had some type of a rectal surgery may need these lubricants, or any type of patient that has a condition where it might harm them if they have to strain. These are your Dococet or your Colace. So your chemical stimulants, again, this is your Cascara, your Senna, your castor oil, or your Dulcolax. It's just another slide that I found on this internet you guys can look at. Your lubricating laxatives, this is your Colace, your glycerin, your mineral oil. These will work in 3 ways. They will directly provide direct chemical stimulation to the GI tract. They're going to cause the production of bulk or increased fluid in the lumen to increase that stool, or it's going to lubricate the intestinal bolus, that food, to promote it to get through the GI tract easier. Indications for our lubricating laxatives. We would use these for patients that are having acute abdominal disorders. No, I'm sorry, I switched pages. Indications: short-term relief of constipation. You would give these to patients. You want to prevent straining. You want to prescribe these for patients who are going to have some type of a diagnostic procedure, and you want to get the bowel completely cleaned out. So maybe a colonoscopy. Sometimes we prescribe them if we want to get out any type of unwanted object that the patient may have swallowed. And sometimes we use this as an adjunct in anthelamic therapy for patients that have parasitic worms. Pharmacokinetics, they are only minimally absorbed, and they exert their therapeutic effect directly inside that GI tract. Contraindications, obviously patients who have severe acute abdominal disorders, we don't want to, cause any extra activity there. Use carefully in patients that are pregnant or lactating. So GI effects, it's always possible to cause diarrhea, abdominal cramping, nausea, dizziness, headache, and weakness sometimes is the effect that it has on the CNS effect. Cardiovascular effects, we can see sweating, palpitations, flushing, and fainting, and there is a high possibility of catharic dependence. So it is if patients use these laxatives a lot, your body gets dependent on them, and then you won't be able to have a bowel movement without them. So you have to use them very carefully. And then depending on what medications you're taking, it can interfere with the timing or the process of absorption. So you just want to think about that. So the types of gastrointestinal stimulants, we have ilopan or Reglan. So ilopan increases acetylcholine levels in the body, and that's going to cause a stimulation on our parasympathetic nervous system. We use it sometimes for the prevention of intestinal atony or loss of intestinal muscle tone for patients post-operative for different operations. Reglan will block dopamine receptors and make the GI cells more sensitive to acetylcholine, which is going to lead to an increase in GI activity and rapid movement of the food through the upper GI tract. It can help relieve GERD, so the food won't stay there long. It'll be rapidly absorbed, propelled along, so we can't bring it back up. And it's also used to prevent nausea and vomiting. So the types, they will stimulate parasympathetic nervous activity within the GI tract. It will increase GI secretions and motility. It is used to rapidly move GI contents. It is rapidly absorbed in the body. It's going to be excreted in the urine. Obviously, we're going to use cautiously with patients who have kidney issues, since it's excreted in the urine. We would not want to use in patients who have a GI obstruction or an allergy. Caution with pregnancy and lactating. Adverse effects, again, decreased blood pressure and heart rate, weakness, fatigue, nausea, vomiting, diarrhea, intestinal spasms, cramping. So remember, with every medication we give, we can always cause the opposite effect. So if we're giving them a medication to make them go to the bathroom, we can give them diarrhea. Diarrhea, if they continue to lose volume, it's going to affect their circulating blood volume. It's going to lower their blood pressure, and then we're going to cause other issues. So these are things that you want to think about. We should always be monitoring their stools when we're giving them these medications. For patients that take these stimulants with digoxin, we're going to see a decreased absorption of the digoxin. Cyclosporine, decreased immunosuppressive effects, so they're going to be at a risk of increased toxicity of that medication as well. And patients that take these with alcohol, we can see an increase in sedation. And these two slides, I'll just put them in there. You guys can take a look at them. So for patients that have diarrhea, we can give them anti-diarrheal medications. So anti-diarrheals will block the stimulation of the patient's GI tract for that symptomatic relief from diarrhea. We have Pepto-Bismol, crofelemer, loperamide, which is also Imodium, and we have opium derivatives too that we can prescribe. So the Pepto-Bismol helps by coating the lining of the GI tract, and it soothes irritation that comes from stimulating those local reflexes to cause an excess GI activity or overstimulation, and then the diarrhea. Loperamide will have an effect on those muscle layers of the GI tract. So it's going to slow peristalsis, and it's going to allow increased time for absorption of those fluid and electrolytes. And then those opium derivatives, they will stimulate spasms within the GI tract, stop peristalsis and diarrhea. One thing to think about with anti-diarrheal medications, if you have a patient comes in and they have a lot of diarrhea, the first thing you probably want to do is you want to ask the doctor to order a stool sample. You want to make sure that it's not C. diff. Giving a patient Imodium in the presence of C. diff is contraindicated. We don't want to stop that. We don't want to stop the patient from being able to get rid of that C. diff if that's really truly what they have. So you will see that even if you forget and you ask for a medication like Imodium, they will ask, the doctor should say, let's get a stool sample first and rule out C. diff before we give it. And then once you get that stool sample and you can rule it out, then the doctor will go ahead and give that medication. So the actions, they will slow the motility of the GI tract through direct action of that GI tract lining, relieve symptoms of acute or chronic diarrhea, reduction of volume of discharge from ileostomy, so how much is producing, and prevention and treatment of travelers' diarrhea, which we get when we go to different countries, drink their water, different foods, things like that. The pharmacokinetics, excuse me, is going to vary upon the agent that we have. Contraindications, obviously, if they have an allergy to the medication. We would want to use cautiously in patients who are pregnant and lactating. If they have a history of any GI obstruction, it can cause an exacerbation of those symptoms. If they have any type of acute abdominal condition going on, it can exacerbate those symptoms. And then for diarrhea associated with poisonings, it can cause it to be worsening. It can cause the side effects to be worse because they're going to slow down that GI tract, and it's going to allow an increased time for absorption of that poison, and we don't want that. So adverse side effects that we may see: constipation, abdominal distension, abdominal discomfort, nausea, dry mouth, toxic megacolon, fatigue, weakness, and dizziness. And then our antiemetic agents, which we would give for patients who are nauseated or vomiting. So sometimes we want to induce vomiting. If they've swallowed something poisonous, we want them to vomit, but in other times we don't. And obviously this reflex that we talked about earlier is not beneficial or wanted by most patients. It's a very uncomfortable issue. So we don't want our patients to be uncomfortable, and we don't want them to be vomiting and losing more volume. So we want to give them something to help. So emetics are medications that we give to patients who we want to vomit. So it's going to cause them to vomit. So these are recommended for at-home poison control. In the hospital, we do it because we want to get rid of that toxin in the body as quickly as possible. Antiemetics we give to decrease or prevent nausea or vomiting. These are going to be, some of these medications act centrally, some of them act locally, and they have, depending on what the medication is, a varying degree of effectiveness. So these are the sites inside the body where these emetics and antiemetics work. You guys can take a look at that. Our centrally acting antiemetics are phenothiazines. Our non-phenothiazines, which is the Reglan. Remember, we just talked about that. It helps with GI motility, but it's also used as an antiemetic for nausea and vomiting. We have our anticholinergics / antihistamines, so our cyclizine, meclizine. We have our serotonin receptor blockers. That's our Zofran or our ondansetron. And then we have our substance P neurokinin 1 receptor antagonists, which is our Amend. So our phenothiazines, they depress various areas in our central nervous system. We would use this for treatment for patients who are nauseated or who are vomiting. Adverse effects of this medication, it can cause drowsiness. So this is also something you want to think about when you're giving that patient who's on pain medicine. Sometimes pain medicine will cause nausea and vomiting for patients. So sometimes they will ask for Zofran or some type of antiemetic, but it's going to cause drowsiness. So is it the narcotic that you're giving. So those are two things that you want to think about. So we're going to be checking blood pressure, respiratory status, how alert they are. You're going to be thinking about that when you're taking care of those patients that are getting a lot of those types of medications together. We have our Reglan. The actions are to reduce the responsiveness of the nerve cells that induce vomiting. Obviously, we're going to use it to prevent nausea and vomiting. It can cause drowsiness, fatigue, restlessness. Some patients will also experience those extrapyramidal symptoms. That involuntary movement, tremors, muscle contractions. We talked about this with some of our other medications. Our anticholinergics, they are going to act as antihistamines and block the transmission of those impulses that cause vomiting. It can cause drowsiness, confusion, dry mouth, anorexia, urinary frequency. Our Zofran will block those receptors associated as well with the nausea and vomiting. It can control We would prescribe it to control nausea and vomiting. It is going to be rapidly absorbed, metabolized in the liver, and excreted in the urine and feces. Used very cautiously in patients who are pregnant and lactating. Side effects, drowsiness, urinary retention, constipation, headache, malaise. Sometimes patients will report when you give it IV that it does burn a little bit. And lastly, our amend. It's going to act directly in the CNS systems to block those receptor sites. We can use it in combination with other agents to help prevent nausea and vomiting. If it's given orally, it's going to be metabolized in the liver and excreted in the urine and the feces. Side effects, fatigue, constipation, diarrhea, anorexia, liver enzyme elevation, and dehydration. So we're going to be looking at our electrolytes and our liver enzyme levels. And that is it for week 13 of pharmacology, NERN 110. If you have any questions, you guys can email me directly. Have a good day.